Hello everybody. Hi, hello, it's nice to see some of you again. So we wanted to take the opportunity to have another just kind of review of where things are at with COVID and talk through some questions that we've been receiving and look at new science that's been evolving. It just continues to amaze me how much things have changed. You know, I think back to 6 months ago and where we were at in December, last time we had one of these. And then I think back to 6 months before that when we were still figuring so many things out. So I do actually sort of really hope that this might be our last COVID town hall. That might be a little bit optimistic, but it does seem like we're on the way forward. So let's just get into it. There's a lot to go over. I don't have any specific disclosures. The vaccine companies still don't pay me any money for anything. So our goals are going to be to kind of just go over where we're at with the epidemiology, talk about some vaccine science, talk about some of the new mask guidance that has come out at different levels, and then go through some frequently asked questions and go from there. I don't see that I can see questions as they're typed in, but you're welcome to do so. And then maybe Tim, if you want to bring them up as we go, and definitely people in the audience, if you have questions, by all means, let me know. So this is one of the maps that I watch. This is the Johns Hopkins Map, and you can see we continue to be in a worldwide pandemic, and United States is still here at the top of the list with most cases and unfortunately most deaths. We do have a very robust public health system, and so I feel like our numbers here are accurate and reliable, at least for the United States. I think other countries, it's harder to know what those counts mean. But I think there's really worldwide, no question that we're going to continue to see waves going forward until the vaccine process catches up worldwide. Right now, the biggest outbreak is in South America. So here's the United States data, and you can see if we look back at November, where we were hit the hardest, we had this big wave that really lasted through February. And I really think it's just interesting looking at the dynamics of vaccine versus disease. You know, really, we can't attribute this downslope to the vaccine at all. There wasn't enough vaccine at that point to do that. But what I want you to notice is we had our first little wave and we never got back to baseline. And we had our second wave and we never got back to that baseline. And then we had our third wave and we didn't get back to the prior baseline. And then something started here and then it faded away. So this is what I attribute the vaccine effect to. This is where what I would have worried about was another wave to some degree. But instead of that, what we're seeing is what is termed exponential decay, where we are just seeing fewer and fewer cases as one person gets infected, and instead of infecting 2.5 other people, they're now maybe infecting 0.25 people, which leads to a decrease in case numbers over time. And then with that, you can see here the delayed kind of tailing off of the death rates as well. So I think this is really interesting data too. This is county level data, looking at deaths per capita, because otherwise it's really hard to get a grip on rural states versus much more populous states like California, for example. I think if you look at a population level, it is also interesting to look along state lines. For example, with our neighbors to the north, what their death rates per capita compared to what Iowa did, or especially here with Minnesota. You know, don't overinterpret this kind of data, but on the other hand, it is interesting to see because viruses certainly don't respect state lines. And this is Iowa in general, and you can actually see that the counties that seem like they came out the best were actually Story and Johnson counties, and I think that's more a reflection of census data saying that we have high populations based on a whole lot of really healthy students that fortunately didn't get very sick from all this. And so here's Iowa in general, our current death rates. I think the New York Times data is just easier to look at compared to the Iowa Department of Public Health website. And you can see that, that our new cases down to 72 a day and really multiple days a week now where no deaths are reported at all. So that is just a huge success. And then this was last week, and hospitalizations were down to 68 total in the state, which again, compared to thousands 6-7 months ago is really incredible. And then this data here was just looking at Iowa and our total causes of death and where we were at here in Story County. So 6,100 Iowans have died, and looking at percentages of folks, and I want you to remember this graph when we get to our vaccine discussion later. So about 60% of the deaths were in people over 80, then 20 and over 70, then 13% over 60. But that does mean that around 700 people between 60 and 69 died. And likewise, down the ages here. And you can see once we get down below 30, there's really very few, really none, no deaths at all, which is a real good thing for the kiddos. So, okay, so, and then here at Mary Greeley, we've had over 500 folks that have been with us and then gotten home again. And we've had 59 deaths. I think probably the number is a little bit higher as we had a number of people transfer to Des Moines that also did not survive. We've got 2 folks in the hospital right now, and 83% of us are vaccinated. And you can see our average numbers compared to averaging in November 28 people per day in-house. We're down to about 2 per day. What's interesting is a couple days ago, we had none, and then all of a sudden we had 3 overnight. So there's still, that potential. I think the other thing that none of the COVID data captures as well is the number of people we saw through these months that were in the hospital and ill related to their COVID experience in November and December. That is reflected through secondary infections they got from the immunosuppression from the virus and treatments. Also decompensations of heart failure and kidney disease, underlying lung disease, where we saw a lot of folks who came in through here that did not have COVID currently, but had it back in this range, but then basically were decompensated from their other chronic illnesses. It feels like we're through that now. It feels like the folks we're seeing in the hospital nowadays are not suffering from COVID in November. That group of people has sort of moved through. So I wanted to talk about vaccines at more length. We'll talk about some real-world studies that have been done since the original big controlled trials that we talked about back in December. I want to talk a little bit about the emerging safety data and just a number of things with vaccines. So let's talk about that. So one challenge with any science-based approach is that science is, attempting to be well controlled for variables. And there's always a question of how is that going to look in the real world when we, do these studies. And a lot of this data comes out of Israel. Israel has a nationalized health system. They basically made an agreement with Pfizer so that they basically gave Pfizer access to their health system in exchange for more vaccines, which, if you're Pfizer, that's a great deal, because then you get to do these types of real world studies in a very data-rich environment. And basically what the Israeli data showed us is that the vaccines worked just exactly as well as they did in the controlled trials. We saw a 90% decrease in the onset of cases, very few hospitalizations, just a few deaths had been reported, and we're talking about, hundreds of thousands of people being vaccinated, deaths related to COVID, I should say. But it did seem like the real world data matched what we saw in the clinical trials, which was incredibly reassuring. This, I thought, was really interesting data. They did a lot of surveillance of people after vaccination to find out were people still getting COVID and they just didn't know it. One of the criticisms of the vaccine trials is that because the vaccines have side effects like low-grade fever and you feel yucky, they're not as truly blinded as a blinded study would be, because the people that got the vaccine, they kind of knew they got the vaccine because they felt crummy afterwards. And so then you might wonder, did that person 3 weeks later or a month later just not go in because they assumed they couldn't have COVID, but they actually did, but it was biased because of their symptoms. Anyway, so doing these surveillance studies can really help with that, because it showed, regardless if somebody came in themselves or not, that there really was not evidence of unexpected infection when they just did a lot of nose swabbing. So there wasn't high rates of asymptomatic disease in vaccinated people that people just didn't feel. And compare that to the unvaccinated cohort here. This data really, again, matched what we saw in the big clinical trials and was very reassuring, I think, that we weren't going to keep seeing asymptomatic virus in people's nose that might be transmissible. This is a question that's come up over and over, and I think it's a great question. Vaccine isn't perfect, it's 90% effective, so what about those 10% of people that can still get COVID? The question is, are they contagious? Basically, the data is emerging that they are markedly less contagious than they would have been if they hadn't had the vaccine. And the reason for that is probably related to the amount of virus in the person's nose in somebody that didn't get the vaccine versus somebody that did. If you have been vaccinated, even if you do get COVID and are symptomatic, if we swab your nose, the amount of virus we actually find in your nose is dramatically less. And remember, that's the virus that then needs to move out and spread to other people. Well, so great. So we're measuring less virus, but is there any way to look at that in the real world? And turns out there is. England has been doing a number of different surveillance studies on vaccinated people that got infected and then went home. And they were able to show about a 40 to 60% decrease in contagiousness or transmission compared to the unvaccinated baseline that they had established previously. So again, nothing is ever going to be 100%, but it is a dramatic decrease in the chance of contagiousness, even if you are positive. So, and like everything in the last year, all of these studies and data that we get, they're all preprints at first because there's so much urgency to get this information. So this is a study that has not yet been peer-reviewed and formally published, but it's already being referenced by other studies as well, and it'll probably be published next month somewhere. This is a question that's come out: how long are the vaccines going to last? And so of the original group of people that got studied, those 60,000 patients, they've been following their antibody levels. And this just got published a couple weeks ago. This is actually closer to 6-month data for these folks. But what you can see is 6 months out from the original vaccination, there was only a mild decrease in the amount of antibody here, some more decrease here. There was some age-dependent decrease here on the bottom one, so these are broken out by age. And so the people that seem like they lost the most antibodies at 6 months were people over 65, which is interesting. This dotted line is what they would consider sort of a neutralizing level of antibody. So far at 6 months out, all different ways of measuring this are still sort of effective and neutralizing of the virus. But this type of discussion is going to be what informs that question of, do we need to consider booster shots going forward? And we are on the cusp of hearing the 1-year data from this group. And I think have your radar up there, because if the one-year data says, antibody levels did wane, that's a clue that we're going to be looking at boosters. If you're hearing at the one-year mark that antibody levels are still protective, then that will make boosters a little bit less likely. I think the safety data continues to reinforce itself. 310 million doses of this vaccine have now been given. It's been given to people that are very ill at baseline, very elderly. We had a number of over 100-year-olds come through. This number here, I think, gets reported in a negative way in some circles, and I just want to clarify that CDC tracks these vaccines very closely, and if anybody dies within a certain amount of time post-vaccination, it is required that you report that. But the key is, remember that we're vaccinating people that are very ill already. They're over 100 years old. They have heart disease. That's kind of the idea. And so as they have looked at these 5,300 folks that have died since vaccination, they have not found any convincing evidence that that's from vaccination. And so a corollary would be, if we gave out 310 million coloring books, you would expect potentially these same 5,300 people to die related to their underlying health conditions. We haven't found that the vaccines seem in any way connected to these people actually dying. But it's important to understand that the CDC keeps track of that data on purpose so that if there's any signal at all, they can find it. With the J&J vaccine, the Johnson & Johnson, this is the one-shot adenovirus platform. There was this issue with blood clots that have come up. It's a kind of a unique blood clot mechanism related to low platelets, not unlike some other kind of autoimmune conditions that we see. We've also seen this type of phenomena induced by COVID itself and also other viruses. Basically, the way I see this is a certain very small group of people, when you turn their immune system on, have this cross reaction with their platelets that causes the risk of blood clots. And so there have been 36 cases that have been sort of confirmed out of almost 12 million doses. These tended to be younger people, so probably are forming a more robust immune response. And there was a link to a unique genetic trait in these people. The challenge is that, when they start picking up on this signal, they put Johnson & Johnson on a pause, which there's actually a large amount of disagreement about that. A lot of people had continued to die from COVID, and this delay actually was mathematically attributed to more people dying from COVID than anything related to the vaccine. But I also think the goal here is building trust in the system, and the system has to be able to identify side effects. And so once they kind of adjudicated that the risk of this one in 300 to 400,000 event was much less likely than COVID itself, that's when J&J sort of got turned back on again. I would also add that now that this process has been well described, it's easier to identify and treat so people don't get as sick from this vaccine side effect. But I also think that J&J just didn't really recover from this from just like a delivery standpoint. I think most people heard about this and said, well, I'll just get the other ones. I would also say that, look at this. They were able to identify 36 out of 12 million doses. And here we've got 300 million doses of the other ones. And we're not getting any signals right now of something like this coming out of those on a grand scale. So it shows me that the monitoring system is working. This is the other one that's come up just recently that they're still working through. Myocarditis and pericarditis is inflammation of the heart and the lining of the heart. We often see cases of this that are attributed to some viral illness. We never can explain where it came from, and they, generally speaking, resolve on their own with supportive care. But it's scary, you come in with chest pain and inflammation of your heart, and it requires treatment. And we actually had one of these cases here, and we talked with the CDC. Our pediatrician group talked with the CDC, and took really good care of that person. They did fine. Generally, these have been mild, and again, 300 cases out of 300 million. So the rates on this are vanishingly low. Even so, you'll hear about that. So when we're thinking about vaccine safety, there's sort of these short-term goals. Vaccines have sort of a 4-week interval where you wonder about side effects, and then an 8-week interval, and that's all based on the way the immune system works, the way it generates antibodies, and generally speaking, if you're not seeing a side effect by 8 weeks post-vaccine, you're probably not going to see one. There has been a lot of, there are folks that will say, well, that's not long enough. We want to wait longer. And I think the question is, how long do you feel like you need to wait before you can conclude nothing else is going to happen? Generally speaking, 2 months is pretty good, but we're actually, a year out now from those original 60,000 people that got vaccinated, and we haven't seen any signals of weirdness, I guess I would say. Nobody is coming up with weird syndromes or anything, and really there's not a great mechanism for concerns that have been raised about long-term risks of cancer or dementia or really any of these things. There's just not a mechanism for how that would actually happen. So I would encourage folks that are waiting for longer-term data. We're a year out, almost 1 billion people worldwide vaccinated. I think we're there. I mean, we've got great long-term safety data now. And if you need to wait 10 to 20 years, you may never get there in terms of how do you know something won't happen in 100 years. At some point you need to conclude the immune system's done what it's going to do, and now you're done. And I think we're there. We're not going to see anything else coming out of this longer-term arm. There's been a lot of questions about how are we doing with immunocompromised patients, and there is a decreased amount of antibody generated, mostly in solid organ transplant patients, so deeper immunosuppression. There are kind of lighter types of immunosuppression, like autoimmune diseases, dialysis, some chemotherapies. It seems like those groups still generate pretty good antibody responses. It's this group of organ transplant people that are on some of the medicines like mycophenolate or rituximab that are least likely to generate antibody. I think the challenge is that the immune response is more than just antibodies. You also have T cells that are involved in that process. And so what we don't know is a lack of an antibody proof of a lack of protection? I don't know that we know the answer to that. And likewise, if you found an antibody in this person, how well does it work if they're otherwise immunocompromised? I don't know that we know the answer to that yet either. What I can share with you is that the one patient that we've had in the hospital after completing a vaccine series, so greater than 2 weeks after vaccine series, was a cancer patient on chemotherapy, and frankly was the kind of patient that I would not have expected to survive last year. And that patient spent 4 days in the hospital with us and then went home on room air. So from that standpoint, I really think the vaccine has done a lot of good and continues to do a lot of good. But I think these numbers here make us worry about the risk these folks have in a otherwise high-risk setting, and so that's where guidelines about continuing to wear masks and be careful about physical distancing come in, especially for this particular group of people. This data I thought was fantastic. So COVID vaccines and pregnancy, this was a big study that came through of folks that had been vaccinated that were pregnant, and many of them healthcare workers, many very early on in the pandemic. As part of the clinical trials or whatever, there's a registry of pregnant folks that have been vaccinated. And I think this captures what is always important when you're trying to think about side effects, is that things happen in the world that are bad and occasionally tragic. And, I've personally gone through this as well in my family. But I think the real question is when tragedy strikes, is it because of a vaccine or was it going to happen anyway? And so when we think about miscarriage, which is always a tragedy, the general rates of miscarriage in the world are somewhere between 10 and 26%. You know, that's a historical average. You know, 1 out of 5 pregnancies can end in miscarriage, and it's tragic. The question is was there any increase in that with the vaccine? And so what we saw was miscarriage rates in vaccinated people were 12.6%. So this was not any different than the historical norms for miscarriage. And that was true of all of these other pregnancy-related outcomes, from preterm birth to small size for baby. All these things weren't any different. And so really, we're not just talking about a pregnant woman, we're also talking about our smallest patients. You know, little fetus in there seemed like they tolerated the vaccine without any difference compared to their historical norms. And the side effects in pregnancy were essentially the same, possibly a little bit less for some of the headaches and feeling crummy, but no difference is big enough to catch your attention. So the vaccine didn't seem like it had any negative side effects for pregnant women. On the other hand, COVID, we know, does increase the risk for pregnant women of poor outcomes compared to non-pregnant, sort of age-matched people. So this was very reassuring. The other thing that has come out that's been interesting is for women that were vaccinated during pregnancy, the amount of protective antibodies in cord blood at the time of birth for baby went up the farther ago that the mother had been vaccinated. So women that had been vaccinated early in pregnancy or earlier had higher levels of protective COVID antibodies in cord blood. So moms are passing these antibodies on to baby. And then finally, COVID vaccine and breastfeeding. So after vaccination, the amount of antibody in breast milk goes up dramatically. And this is also felt to be protective for breastfeeding babies. So far, little ones can't be vaccinated, but indirectly through breastfeeding, they can be offered some degree of protection. And I just have to share, today is the twins' birthday, so we're 1 year out. It's just kind of unbelievable how quickly a year goes. So Catherine is here and Elizabeth is here, and you know, so they are getting some degree of passive antibody through breastfeeding, which, you know, has been very reassuring. So this is interesting. This has been coming out over the past couple months. You've probably heard about this. So a big study came out looking at adolescents, and based on that study, which we'll look at, an emergency use authorization was granted to Pfizer. We anticipate Moderna will get that as well. This is a drawing of a picture of my daughter and her 2 friends. They really wanted to sign up and join the fight as soon as they could. So that's them with their vaccine cards and their COVID shot, and I was really proud of them for wanting to do that. So this is the data. Basically, these kiddos that got vaccinated, none of them ended up going on to get COVID. So there was 100% effectiveness when we looked at 1,000 kids. I think it was 1,000. Number was something like that. Yeah, 1,000 compared to 1,000 folks that had not been vaccinated. You know, not high numbers because we were already coming down in the pandemic, but again, the vaccine works just as well, it seems, in kids compared to their adult friends. And here's a side effect profile after the second shot, which is very close to what we saw with adults. You know, 60% some fatigue, some headaches, some chills. Of these 1,000 kids that got this, we did not see really any grade 4 side effects. This is the group that is being watched very closely for that myocarditis and pericarditis phenomenon. So far, it doesn't seem like it's coming through at a very high rate or with any severity. So I think one question that's come up to me a number of times is, you know, so kids don't seem like they get that sick. And I think that's true. And I think that's something to be grateful for. These are data from early in the pandemic, January to May last year. And if we look at the 10 to 19-year-old group, you know, looking at hospitalizations, there was 1,200 hospitalizations and total, and of the ones they looked at that had immune issue or underlying health conditions, is actually 15% of kids with underlying health conditions ended up getting hospitalized, so not a small amount. And without an underlying hospital healthcare condition, it was 2.5%. Looking at death rates, what you can see is the numbers have, again, fortunately been very low. So death rates around 0.1. For kids that had an underlying health condition, getting COVID put them at about a 1 in 20 chance of dying. So that is not low. That is something that we need to pay attention to. And so especially kids with health conditions, there is a potential risk of severe illness and death. For those that did not have underlying health conditions, 2 out of 2,000 reported here. And I don't have any reason to think that this data from last year would be any different now. So risks are low, yes. 1 in 1,000, that's low, yes. I think when you ask yourself about kids, is it low enough that we should not do vaccinations? And I guess I feel like, especially this year, but also this year makes me think that there's value in vaccinating even kiddos. We've also had this multi-system inflammatory syndrome. Here in Iowa, we've had somewhere between 25 and 49 cases total. That disease, which is basically an immune response to COVID that causes all sorts of organ disruption, and we've seen that with other viruses in the past too. The amount of that has followed the pandemic almost exactly, and so there's very little of it now, but there was quite a few cases early on. The average age was age 9. So that's not respiratory disease from COVID, it's actually almost like an autoimmune process or a reactive immune process to the virus. So it can be severe, unfortunately. So this is interesting data that's old. Back when the Prevnar vaccine came out, not Prevnar, back then it was called something else. Anyway, the Strep vaccine. So little kids get bad strep infections, or they used to. They used to get meningitis, they get terrible pneumonia, and it's tragic. You have this like normal little kid who gets terrible meningitis and is disabled afterwards. So they came up with strep vaccination for kiddos, and a lot of kiddos get this. And they saw the rates of severe disease in kids plummet with the vaccine by the time it was in wide use. What was interesting was none of these 65-year-olds had access to that vaccine, but the rates in 65-year-olds of severe invasive life-threatening disease went down significantly and actually continued to go down even before any of these people were actually getting the vaccine. So the reservoir of disease in kiddos does transfer into the adult population. And so, in some sense, vaccinating kids is actually helping everybody else in the meantime. And it's helping them too. So, in general, COVID vaccination, we're about 6 months in or so. They're safe, they work, they decrease the chance of spreading disease. They're probably going to allow more flexibility with travel, whether or not you agree with that. They're going to allow more flexibility with mask wearing. They will likely prevent disruption. So my kiddo got a cold a couple weeks ago, and we need to get her tested for COVID. She wasn't worried about having COVID. She was worried about missing soccer the next weekend. And so I think that is a thing. You think about the disruption of getting COVID in the world as it is, and if vaccination keeps your family from ending up in quarantine and all this stuff, there may actually be sort of those more logistical benefits too. And I also think that a lot of people just have a general sense of feeling more protected and having less worry. So there's all sorts of benefits. And again, 310 million doses in, these seem to be very safe. There's a number of different products. We're going to skip this. Worldwide, efforts continue. The United States is about here, so kind of in the upper part of the pack. We had an early surge as we got vaccine. You can see they've slowed down, but not totally tapered off. Israel kind of vaccinated everybody that wanted it, and now they're pretty stable. Canada's just given everybody one vaccine, but only 15% of Canadians have had both, so they look really good here, but they're probably not as protected as they hope. And then you can see here other areas in the world, and we'll just look at kind of some higher level data. are catching up still. So South America, Asia, and then Africa still has a ways to go. So I think, viruses and infections don't respect country lines or borders, and they will move around. And the more that COVID is circulating in other areas of the world, the more likely it is that more dangerous variants are going to emerge, which may be less sensitive to our vaccine. So vaccinating as many people as possible worldwide does actually protect us locally as well. And I think we need to continue encouraging our government to do what they can to support other countries in that vein. Here in Iowa, what percent of us are vaccinated? So it's just interesting, greater than 80% of 65 and up people are vaccinated, and then it trails off down after that. This is from late last week. I expect this number to go up. Even the earliest kids that got vaccinated, they just hit full immunity last Friday. So, but I don't have a great sense for how many kids in this group are getting vaccinated yet. But these people have had access to the vaccine for a long time. And I want you to remember that, this group of people did account for hundreds of deaths here in Iowa. So I think this is where there's work to be done in terms of helping people get their questions answered about the vaccine and feel more comfortable about how they work and how safe they are. Here, looking at Story County in general, we are at 49% fully vaccinated of our entire population. I find that a little hard to interpret because of the students not knowing exactly how they're counted, but still, we're at about 50% fully vaccinated. If we look at this broken out by age by New York Times, I thought this was great. 93% of people over 65 are fully vaccinated. So Story County is way ahead of the curve in terms of, folks that are actually at risk actually getting vaccinated. And so that's kudos to public health. Way to go. And in general, Iowa doesn't look too bad. Just looking at kind of the shades of green here, Iowa is doing okay compared to some of our southern friends. I think we can do more and do better. So looking at masks, these are just some of the studies that have shown how masks work. They work in all settings, they work in all ways. Masks are effective. I think it seems to me like there's been a little bit of a disconnect between folks that say they don't work at all or people that say they work with almost like a religious faith. And it's neither. It's in between. Masks offer a benefit. They block viral particles. And it seems to me like these numbers here of, a 70% sort of decrease in transmission risk seems to sort of hit the number that I've seen coming out in various studies. Think about, the old glitter analogy or just in general, if you're up here on the curve where there is a ton of virus, you're, stuck at home with a family member that's coughing all over you all day, it doesn't matter if you wear a mask or not. It will decrease the amount of virus that you encounter, and you'll still have enough virus here to cause an infection. So there's a lot of virus, this person's coughing everywhere, you wore your mask, and it still got in. That's true just because of the concentration of virus. What is happening, though, is this person has less virus in their lungs than this person does. And so this person is less likely to get as sick. So even if you get infected wearing a mask, you're less likely to get as ill. If you're in a low virus area, like in a store or someplace you're passing through transiently, these masks are able to block enough viral particles that you never actually achieve an infectious dose, and so you never actually get sick. So masks have proven, again, multiple studies, and this is just a few of them, that they're quite effective at preventing transmission. But we are in this sort of new era where things have changed so dramatically. So the number of cases that we have is way down, as I showed you. The vaccines are widely available should you choose to get them, and they're very effective and very safe. The data on masking and social distancing, I think, has matured to the point that we have better sense of, is a mask outdoors very necessary? Probably not. It probably doesn't add that much because there's just so much air diffusion going on. And then understanding how viruses actually move around, that has grown. And so I think what is, and many things, what's difficult is, they were having to make decisions about mask recommendations a year ago with a very different set of data, not knowing a lot of these things. And I think as we've gotten more information, it's helped us make better recommendations about when masks are most helpful. I do think, though, especially with something like a mask where it's like a yes or no, it's off or on, you do eventually reach this tipping point where it seems like a very small change in, say, the number of viruses in the community or within your institution, the number of people vaccinated, you all of a sudden can see these switches that seem like they just get flipped. One day you're recommending masks, and the next day we're saying we're no longer recommending masks. How can that be? Remember, there's this accumulation of data that's happening, and you don't want to make a change too soon because what you don't want is to then have to switch back again after you've made the decision. But eventually you reach this tipping point where all of a sudden the accumulation or the emergence of that data pushes you in another direction. And I think that's what, all these numbers getting better, for example. So I think that's what drove, as the CDC started giving us more guidance in the last 6 weeks, 8 weeks now about mask wearing. So first they changed outdoor guidance, and, really they said for vaccinated people especially, only a very crowded event would you need to consider wearing a mask. And I would say that's generally true. For me personally, I might put a mask on as I'm going into the football game, shoulder to shoulder with 1,000 people, but maybe once I'm actually there, it might be okay to not have one because you're outdoors and you're vaccinated and it's fine. If you're unvaccinated, especially in those tight, packed areas, even though it's outdoors, there is still risk of transmission. But I also think for generally speaking outdoors, I would even disagree with the CDC to some degree on this one. I think for even unvaccinated people, when you're outside in kind of a small group of people, the benefit of wearing a mask is just not there. So anyway, then the CDC came through just over a month ago and said that if you're vaccinated, you don't need to wear a mask indoors anymore, which I think was a little bit unexpected for many people. But, looking at the science of transmission and how well the masks work and how much COVID is actually going around, and with how well the vaccines work, this was actually a science-based decision that sort of said it's just not adding much anymore. There's been plenty of criticism of that, saying, now we're kind of putting it on individuals to just protect themselves rather than taking a true sort of public and shared approach. But I think the alternative is, how long would we wait to go here, and what other benchmarks were we waiting for? And I just couldn't come up with much what else we should be waiting for. So I think I was taken aback by all of a sudden this changed. And then what we saw is a very rapid succession of private businesses and organizations changing along with it as they chose. Some places have not changed any sort of mask recommendations for their own businesses. And, that's kind of the benefit of looking at your own situation and making a decision. But again, it's a much more individualized approach rather than a public kind of everybody in it together approach. And I think the folks that get a little bit left behind with this approach are people that are really immunocompromised, because now it's just on them to have to wear a mask and get vaccinated, even if it may not work that well. Here in healthcare, we were an exception. They want us to keep wearing masks. And so you might say, well, wait, you just told us all these reasons we didn't have to, but this is really what it boils down to. We're taking care of sick people, people that are already vulnerable, people that may not want to be here. And so they are at high risk of getting infected in general. They're also more likely to encounter people that actually have COVID because we're a healthcare facility. Also, the group of people that come into this facility are much more likely to be immunocompromised than the general public. Also, when we look at what happened in our nursing homes a year plus ago, those folks are immunocompromised, and COVID just really tore through places. And so what we don't know from a certainty standpoint is, what are these new variants going to do with, how are they going to interact with our vaccine? And what would be very sad would be to stop taking precautions in places like nursing facilities only to have a new variant come along, the Kappa variant or something, that totally ignores our vaccines, and all of a sudden we're right back to March last year. I don't think that would happen, but again, that's the uncertainty that we're still sort of chewing through as these guidelines are coming out. I would also share that there's more than just COVID, which I know from personal experience, having gotten a bad respiratory virus last week, and I tested negative for COVID, which was fantastic. But again, last Tuesday, we changed our mask rules, and so I wasn't wearing my mask in my office, and Nasreen, my nurse, promptly got a really bad respiratory illness from me, and I felt terrible about that. So just remember, there's more than just COVID, and so that's not necessarily a reason that we all have to wear masks forever, but it's just things move around. It was a proof of concept. You take the mask off and viruses will move around. This came out May 20th. Iowa legislature passed a law prohibiting public institutions from requiring masks. It didn't prevent private institutions from requiring masks, but would prevent them from getting public money. I'm not going to say a lot about that other than it seems like we got through the last few weeks of school without any major outbreaks, and I'm grateful for that. I think it will limit the tools we have in our toolbox next fall. If we're having, localized COVID outbreaks, how are we going to respond to that if we don't have masks as a tool? But laws get changed all the time, so I think we'll just kind of contend with that as it comes. And so then I think you're all familiar with, I guess it's been 2 weeks now, that we also took the steps of saying that for fully vaccinated people in a setting like this, there's no patients around, the vulnerability of folks should be no more than the general population, that people can take off their masks. But we are asking that unvaccinated people continue to wear masks for now. And, this is something that we've also done with influenza, epidemics in the past. And I think it will be largely driven by community numbers. But I don't have a specific benchmark to tell you about what number we're waiting for. Again, there's just a lot of uncertainty about variants and what we're going to see going forward. I would view this as a step-by-step approach, wanting to make sure that nothing dramatic happens with this easing off before we go to this easing off. I would also encourage folks that if you haven't been vaccinated yet, it's time to look at the data again and look at that safety data and how it's really grown over the past year, and maybe it's time to make the jump and join the fight. And we're seeing our peer institutions do this as well. And I think the reality is that y'all were taking your masks off in your office anyway. And so was I, and it's fine. So just keep being thoughtful. This was a wrinkle that happened last week. OSHA, kind of a federal regulator for workplaces, decided to publish their recommendations. It was a strange time to publish those since we seem like we're all going in the right direction. But either way, we may have to backtrack on a few of the things that we had changed, like taking down some of the barriers, only because these are regulations that we can't avoid. We are waiting to see if there's any sort of pushback from at the federal level about some of those changes, especially in very low prevalence areas. But at the end of the day, regulations are going to be regulations. And if you see things that seem like, wait, that seems like it's going the wrong way, it might be related to these OSHA things. Fortunately, we're mostly clear with this. There'd be only very subtle things that we might have to change. Okay, I'm going to start going through some frequently asked questions that I've gotten. If you have questions, by all means, shout them out or whatever. Otherwise, I'm just going to work my way down. Will there be boosters? I already kind of mentioned the two factors we're waiting on are how long does immunity last and what do the variants do? the variants, instead of the B.1.1.07, instead now they're being called by alpha, beta, gamma, delta. So far, the vaccines seem to maintain their efficacy against all the variants that we have, at least to a sufficient degree that we're not needing to do boosters yet. But we continue to have new variants coming out. And then I'm going to jump to the bottom one. Are we checking for variants? So Iowa Department of Public Health is actively checking for variants. You don't have to request that. It's an automated process where they do a certain number of sequencing on a percentage of the positive tests that they get. I would say that if you have a patient that ends up in the hospital critically ill after a vaccine, you will want to let Public Health Department know that to see if that's one they want to sequence to specifically say, is this one a particular variant? The thing about these variants is that as they change, so this is a little spike protein, which is built of all these itty bitty protein parts called amino acids that then fold together to make this thing. So one little subtle change in this might make this protein stick to your cell a little bit better, and that is going to be what makes it more contagious. And so, for example, in England, here we have April, they were doing okay. They were having a decreased number of COVID cases based on the environment they were creating with their masks and distancing and all of those things. They were decreasing. Then the Delta variant arrived, which is more contagious, and you see what almost looks like what we saw in March, taking off of this new virus. So what's going on? The variant is contagious enough that whatever masking and distancing and vaccine things they were doing as a whole were not controlling this to a sufficient degree. So that is where you may see, and this was mostly unvaccinated people, but it might be that, here in Iowa, those 50% of people that are not vaccinated are doing fine right now based on our current variants, but if we get a new one, we may all of a sudden see a surge of, I don't think anything like November, but of folks coming in with a new thing, and then that will eventually become the dominant variant in our area. They also might cause more severe illness. I haven't seen convincing evidence of that. They also might be less severe. It might be more contagious but not make you as ill, which I think we'd all love. And then also, are they less sensitive to the vaccines? So far, we seem like we're doing okay. And remember, how effective a vaccine is depends on how much antibody it generates. So they might say that a certain variant is less sensitive to a vaccine, but as long as the vaccine is still up above that dotted line, even if it's gone down, you're still okay. You're still protected. That is also part of the recommendation for why somebody that had already had COVID and recovered from it with their own immune response would still want to get a vaccine. When we measure antibody levels post natural COVID versus post-vaccine, actually antibody levels are higher post-vaccine. So the length and duration of protection might be longer and better actually with vaccination. The other interesting thing was that when they took somebody that had COVID and had a natural antibody, and they compared that antibody to somebody that had COVID and had a vaccine, and they compared that immune response, and they exposed both of those people to a new variant, the person that had been vaccinated responded better, probably because their immune system had been trained and retrained how to do this best. So it's for that reason that even if you've had COVID, getting vaccinated is worthwhile. And I think natural immunity is fantastic, and I'm glad we have it. And sometimes it is better than vaccine immunity, depending on the disease. In this case, it seems like vaccination is actually probably a more robust response. So, should I have my antibodies checked after I've been vaccinated? So, generally speaking, definitely not. It's not worth it. This is more of a question for our immunocompromised patients. And I think the challenge we have here is, if we check your antibodies and they're positive, I'm still not sure how long they'll last or how well they work because of your immune system. If we check your antibodies and they're negative, I don't know that you're not protected because you have other parts of your immune system. And also there's been no studies that I'm aware of that tested a third or fourth or fifth dose of vaccination, specifically the safety of those things. I think they would be, but without knowing that, nobody's going to be offering extra doses. So if it's not going to change what we do, I'm not sure it's worth doing. So I'm recommending against checking antibodies even in immunocompromised people because it's just not going to change anything right now. I think we've answered this one. Once I'm vaccinated, can I pass it on? It is still possible, but it is dramatically less likely that you'll be contagious. Will we have vaccines for kids less than 12? I think so. Studies are ongoing. We have to make sure that they're safe and that they actually work. I have heard estimates that we might get that data out by September. So, not quite in time for school, but potentially early in the year, in the school year. I've heard two things. I've heard these studies going down to age 5, and I've heard these studies going down to age 2. It might be that different companies are testing them in different ways. So many people ask me what I'm doing personally. And I can tell you that it's tough. It's vexing for me because I have also a 10 and a 5-year-old that have not been vaccinated, and I want to support them in their mask wearing. And so I try to wear a mask when they're around, especially at church or going to a store. Because of that, it's so much of a habit. I've just continued to wear a mask when I'm in any sort of non-very environment that I'm not super used to. But then, like last week at church, I thought I forgot my mask and was like, oh, it's fine, whatever, I'm not worried about it. And then I found my mask, and 10 minutes in, then I put it on again. And I'm sure everybody around me was like, that person's crazy. He can't make up his mind. I think generally speaking, the vaccines work. And I think people not wearing masks in public settings are protected. But I also think that as a community, we have a lot of people that have immune-related issues, and sometimes having more people wearing masks normalizes it and makes it easier for those immune-compromised people to feel less marginalized. So I don't think this is something we should be arguing about. I think you can go either way on this. But I do think that for folks that are really anxious, just because of the year we've had, I want to reassure you the vaccines work. So you can start taking your mask off. I mean, I really think that we're getting there. And then what do I think about XYZ on the internet? So I get a lot of sort of questions about really strange things that you might see or read on the internet. And I think the key is always to try and understand why the person was looking on the internet for those things, because often it's part of a conversation about vaccinations and are they safe. And then trying to share your personal experience, and also trying to encourage people that if they have questions, to talk with their physician. I really think at this point, a lot of the conversation about vaccinations could be happening in provider offices. And my personal example is, I was playing soccer last week and I hurt my leg, and I thought I looked it up and I knew what was going on, but then I went and I saw my doctor, and my doctor knows all sorts of things about this stuff and was able to share a very rich and deep context for what a calf tear is like in reality, much more than I would have been able to get on the internet. And that's, me as a physician. So for folks that are having questions or doubts or reading things on the internet, I really think taking some time to talk with providers is a good idea. There's a lot out there, and a lot of it, what's interesting is a lot of it is being generated by a very small group of people that don't want people vaccinated, but then it spreads. So people should talk to their providers and try and get good, reliable, trusted information. So, the road ahead, I think we will see some increase in the fall amongst unvaccinated people. Just like we saw, our big wave last fall, there's changes with the weather and indoors and all that stuff that if you're not vaccinated, this will continue to spread. The virus, it doesn't care what % of us is vaccinated. If it's got enough people, it'll move around. As I said, we're transitioning from a public health more to personal responsibility type of response, for good or for ill. But I think that means that we all have a role to play in helping make sure that our community is getting vaccinated. How bad it gets will really depend on those vaccination rates and any variants. And then we really need to keep pushing to get vaccines out to places in the world that don't have access to them. And I think, lastly, I would just say that we can keep being kind when we have these conversations and keep working together to just, help people answer the questions that they have, but don't take kindness as a reason to not reach out to people that you think might benefit from getting vaccinated. And that's friends and family, it's neighbors. Like I said, we don't have to argue, but I do think that now's a moment that if we can get another 10, 15, 20% of us vaccinated, it'll make a huge difference in the fall. So I think I'll open it up for any questions from there. When I think about these presentations, I think about metaphors a lot. And the one that I just couldn't get away from was that vaccines are kind of like pants. Like, pants are good. I like wearing pants. And there are times when maybe I wish, pants weren't made by huge corporations that make a ton of money, but at the end of the day, they're making good product. Levi's makes good pants, and so I still wear pants. Like, it's not a reason not to get them. And if you don't wear them, you might feel like you wish you had. Even though, no shirt, no shoes, no service, they don't necessarily mention pants. Like, you can, they're maybe not even required, but it's still a good idea. So these are some Minnesotans that froze their pants, and then they, do art with them. So anyway, you can play around with that metaphor as much as you want, but I find vaccines to be a useful tool, and I think the more of us that are wearing them, the better, or using them. Anyway, so I'll leave it there. And any questions from the crowd or from the internet?
Dr. Fulton?
Yeah.
What do you expect is going to happen with the Delta variant here in the U.S.? After watching what's happened in the UK, do you think we're going to say the same thing here?
It will. I mean, math will say that it will. I mean, it is more contagious, and so it's just a matter of time before, it reaches dominance. It seems still unclear if it's a more severe illness or not. There's been some discussion, but it's always hard to tell early on because you're checking the more severely ill people first, But I do think that just if the R naught of our current virus is now less than 1, 0.25, and if the R naught of the Delta is anywhere over 1, it'll spread and preferentially get passed on. And it does seem like the vaccine is effective still against it, so. That's a good, so there's a question about a family member who got a vaccination and tragically was in a car accident and then had to have, had a lot of blood loss and had spleen removed. And, I think what we can say is that the first vaccine we know does offer a solid protection. Estimates are 60 to 80% effective. The second vaccine seems like it pushes it up above that. I would not be surprised if we end up into the realm of needing booster shots, that would just be where you end up going with a family member that you're not sure about the second dose. But it's really hard to know how much that second vaccine did because of the, all the stress that your mom was under. So I hope she recovers quickly. So this is a question about, based on the risk factors we have here in healthcare, are we ever going to be able to stop wearing masks? And so the answer is yes. I mean, we're not going to wear masks forever. I think, I think we all had this notion that the pandemic would be a months-long process, not over a year process. And then, all of a sudden it's like, are we going to have to do it all next year too? I don't know for sure how long it'll be, but we will get to a point where There's little enough disease, and we know enough about it, and enough people have been vaccinated that I think we won't be wearing masks all the time. Whether or not we achieve that this summer or not, I don't know the answer to that. I'm suspecting that, well, vaccine rates in our community are still under 50%, and we still have over 100 Americans dying every day, that we'll continue to do this in a healthcare setting until we get more data about how long the vaccines last to give us some confidence there, and then to see, do we get into a realm of boosters where there's some regularity, or do we need that or not? So I'm going to not totally answer that question, but it won't be forever, but it may not be this summer. I think we may, with patient interactions, keep wearing masks through the summer and into next fall when I expect a bump, and then maybe after that. Just like we've done with influenza. It's just influenza's been seasonal and not all year long. Is temperature checking still recommended? So that's a good question. We're kind of required by CMS to do temperature checks, which is why we're doing them here in the hospital. I think probably what we've learned is checking temperatures may not actually add that much. People generally know when they're sick, and I don't think we pick up, especially in a low prevalence time, the likelihood that a temperature is going to pick up an asymptomatic or pre-symptomatic COVID case now is not very high, and so they've stopped doing that in the clinic. But we still have requirements that are federally regulated, so we're going to continue doing that as long as we're required to. I don't check my temperature every day. I think it was used for a while as sort of a surrogate in big settings like the university too, of how to help people understand who was sick and who wasn't, and just kind of be more self-aware of health. But I don't think long-term screening of temperature is going to be something we end up doing. I think that's going to go away, maybe even this summer, depending on if CMS makes changes. Amber, are you hearing anything about that? No. Okay. Yeah. So we're kind of dependent on CMS to tell us what we can and can't do on that. And sometimes it's just like a subtle change in the language too, where what was must turns into may or something like that, and then right away then we get the power back to make our own decision, and then we look at that. And if numbers are low and we're doing okay, we'll probably just stop it.
And Iowa hospitals are meeting in early July to talk through all this as a Iowa health system. What is
okay? So Amber Deerdorf is saying that the Iowa coalition of hospitals is meeting to talk about all this stuff too, and probably all the OSHA stuff and everything else. And I think that is always something so important to bring up, that we never make decisions without talking with our peers, and we are in deep debt to, the infection prevention teams at the university and at Mercy and Methodist for sharing their knowledge and allowing us to share ours. But I think in general, we are doing these moves in concert with them as well.
I have a question about that. You
Yeah.
referred to influenza and COVID masks. Will we ever get to the point where vaccination, we don't have to wear a mask, and if you haven't had the vaccination, you wear a mask like we do with the influenza?
Potentially. I mean, to some degree we are now in non-patient care areas, but I think you're talking about patient care. Yeah, I think it's hard for me to imagine there being a recommendation. Well, it would depend on numbers. I guess if COVID just melted away and never came back, it wouldn't be an issue. But presuming it stays around and presuming it stays seasonal, I imagine that the recommendation is going to be that vaccinated people will reach a point where they don't need to wear masks, even with patient care, and that unvaccinated folks continue to do so just like they do with influenza. I've also heard that there's been a lot of talk about the booster shot, I think because it's just such a logistical challenge to, how do you send out a booster to 300 million people or whatever? So they're preparing for that, even though we don't know for sure we're going to need it. But I've also heard that there's big hopes that they would co-formulate that with the influenza shot, so it would just be one shot. You would get your influenza vaccine and COVID update booster at the same time. Yeah.
Got another question. Herd immunity, with what you know and what you read, in between the percentage, and let's talk about the U.S. here now, percentages of gotten the vaccination, where we're going, and then figuring out how many people have had COVID and haven't had the vaccine, and then adding all that up. Do you think there's any chance we're going to reach herd immunity, or is that a lost cause?
So herd immunity is the concept that enough people are vaccinated that even if the virus does show up in one person, it may infect one or two people right around that person, but because so many people have immunity and protection that that it is not able to spread, beyond that. And so even the next person out, the next layer out, even if that person's unvaccinated, their risk is dramatically lower because so many other people are protected and it just never gets through. It seems to me like we're unlikely to achieve that with this virus, at least anytime soon. Looking at our 50% vaccination rates plus, a certain percent of natural immunity on top of that. I think if you look at these curves, this comes down for a reason. It comes down because whatever the local networks of spread are, they've been exhausted by the virus at that point. All of the people in those networks have been infected and no longer can get it, and it doesn't just keep bouncing around. But maybe I'm just being pessimistic, but I just think even if we kind of get enough people vaccinated, we are going to continue to have COVID-19 as a pathogen that we have to pay attention to long into the future. To some degree, what is this? This is seasonality. We're doing better there. The vaccine is working. We're doing better there. A lot of folks have already had it, so we're doing better there. But if you look at same time of year last year, this was the Florida bump, really. We were doing really good last year this time, too. So I would not be surprised if we keep seeing those bumps. What would it take to actually achieve herd immunity? It depends on the variant, how easily it's spread. And I think as the variants have shown higher and higher rates of spread, it gets harder and harder to achieve. And that's why you've maybe seen that estimate move up. Initially they said 60% will get to herd immunity. Well, that was based on the transmissibility of the initial virus. But as the variants have been more and more transmissible, that's why that number's gone up to 70 and now even 80% you hear said as a range. And that gets hard to achieve, especially just looking at our community, our country, and how difficult it's been even so far to get folks vaccinated. But make no mistake, a difference in 10% in a population has huge implications, not just for this curve, but for this curve. And people making the decision to vaccinate themselves may actually save their neighbor's life. Well, I'd like to thank you all for coming. Again, hopefully this is our last time together, but you never know. So, all the best. Thank you.